In acute coronary syndrome, delays from the onset of symptoms to the specific management determines the outcome. These delays include pre-hospital delay, that is the onset of symptoms to specific management, and hospital delay. The onset of symptoms to first ECG, door to needle time, arrival to specific management, and door to balloon time. According to the literature, documented pre-hospital delays are as follows. In Europe, the documented pre-hospital delay for STEMI is 2.3 hours and for non-STEMI is 3.1 hours. And for USA, it's 2 hours for the STEMI, 2.6 hours for non-STEMI. In Australia, 1.7 hours for STEMI and 2.9 hours for non-STEMI. In Sri Lanka, documented pre-hospital delay is 1 hour for STEMI and 2 hours for non-STEMI and unstable angina. It is likely that the current economic crisis may affect pre-hospital delay. Therefore, our objective is to assess the pre-hospital delay in acute coronary syndrome patients during economic crisis. This was a prospective cross-sectional study using consecutive patients admitted with acute coronary syndrome to Professorial Medical Unit, Colombo North Teaching Hospital from May to July 2022. A pre-tested interviewer-administered questionnaire was used to gather information following informed written consent. Outcome data were documented using hospital records. Statistical analysis done using SPSS software version 26. Our study consisted of 105 patients with a male preponderance of 59%. Mean age was 64 years with standard deviation of 12. During our study period, 25% presented with STEMI, 61% presented with non-STEMI, and 14% presented with unstable angina. Even though 98% of the patients knew that they should take treatment as soon as possible at the onset of symptoms and they should go to hospital as soon as possible, less than 1% knew about it should be within 2 hours. Although 13 patients knew about taking stat doses at the onset of symptoms, only 2 of them took stat doses, mainly due to 4 of them had defaulted clinic follow-up and 4 patients due to unavailability of medications at home, and 3 of them didn't care about taking medications even though they had medications at home. According to our study, the median in-house delay was 4 hours for STEMI, 5 hours for non-STEMI or unstable angina, 5 hours for all acute coronary syndrome. Median transport delay was around 1 hour for all acute coronary syndrome patients. The median pre-hospital delay was 5 hours for STEMI with the interquartile range of 3.5 to 30.8 hours, and median pre-hospital delay for non-STEMI or unstable angina was 6 hours with the interquartile range of 3.5 to 24.5 hours, and for all acute coronary syndrome, the median pre-hospital delay was 6 hours with the interquartile range of 3.5 to 24.5 hours. This graph shows the comparison of pre-hospital delay in our study with the previously published data during 2015. According to that, in our study, the patients presented with STEMI, non-STEMI or unstable angina and all acute coronary syndrome showed a significantly higher pre-hospital delay compared to 2015. When considering the pre-hospital delay, only 9.5% of patients presented to first medical contact within 2 hours. Around 27% presented after 1 day. When analyzing the reasons for the pre-hospital delay, 87% had combined reasons for the delay. 61% got delays because they waited till symptoms settled with routine medication. 59% got delayed because they didn't realize that the symptoms were serious. Around 62% got delayed due to unavailability of the mode of transport, and around 48% got delayed due to cost factors, and around 36% got delayed due to unavailability of fare. Around 98% knew about the Suvasaria ambulance service, and also 94% knew the contact details, but only 5 called and 3 experienced a delay in service. During our study, around 34% patients developed complications. Among them, 31% had left ventricular failure, around 6% got arrhythmia. According to the regression analysis, pre-hospital delay was found to be an independent predictor for the complications. Around 2% of the patients required ICU care and around 3.8% needed HDU care. Our conclusion is, we observed contribution of economic crisis related barriers and poor awareness on illness for pre-hospital delay in acute coronary syndrome care. I acknowledge all study participants and the staff in Professorial Medical Unit, Colombo North Teaching Hospital. Thank you. Good afternoon. I am Nimasha Ekanayaka, currently working as the demonstrator in the Department of Medicine, University of Kelaniya. Our study is cricket in a bubble, the effectiveness of maintenance of the biosecure environment during the COVID-19 pandemic. The COVID-19 pandemic imposed unique and unfamiliar stress on different population groups, including sporting codes. Biobubble is a new concept introduced during COVID-19 for sportspersons and their support staff to reinstitute sporting events. With biosecure environment, also called managed event environment for cricket matches, the Sri Lanka Cricket along with International Cricket Council aim to minimize the transmission of COVID-19 infection during ongoing tournaments and bilateral series. This essentially involves instituting protocols to be followed during hotel stay, travel or transportation to venues, training sessions, actual sport events and recreational sports. Sri Lanka Cricket Medical Committee along with International Cricket Council developed these biosecure environment guidelines considering existing countries' guidelines and the pattern of community spread of COVID-19. Therefore, this study was designed to assess the effectiveness of COVID-19 containment, mitigation measures, and the outcome of the maintenance of the biosecure environment during international inbound cricket tournaments. We performed a descriptive study. It was a retrospective data analysis from existing database which was maintained by medical officers in charge in institutes of sports medicine of each inbound cricket tournament. Data had been collected by medical officers within each residence of each cricket tournament which maintained biosecure environment from August to December 2021 in Sri Lanka. All Sri Lankan teams, visiting cricket team members, support staff, security and match venue ground staff within each biosecure environment during the study period were included. Data analysis performed using SPSS statistical software version 26 and the Ethical Review Committee at the Faculty of Medicine, University of Kelaniya approved the study. Our study population consists of 1,232 study participants. Number of tournaments held during the study period was 6, which included 15 events. Number of residences maintained biosecure environment is 15. COVID-19 testing were performed according to the guidelines provided, and the COVID-19 test coverage is 100%. Among them, 7 study participants got positive for COVID-19 PCR testing. None of them were positive for COVID-19 antibody testing. Several measures taken for the test positives to prevent the disease spread. Among them, 2 test positives isolated in the same place. 1 person transferred to the intermediate care center, and among them 4 out of 7 PCR positives sent for home quarantine. Further, first contact tracing was arranged with COVID-19 PCR testing in collaboration with the MOH areas of each test positive member. Members of 5 events, total of 15 members, who needed to leave the bubble in unavoidable circumstances, green corridor or the safe corridors had been created. None of them got positive for COVID-19 infection following leaving the bubble under the safe corridor. Therefore, the effectiveness of the green corridors created was 100%. When considering the outcomes of our study, total participants with confirmed COVID-19 infections were 7 out of 1,232 participants. That is only 0.56%. 4 tours, including 12 events, were completed with 0 test positivity. No matches were cancelled. No serious illness reported among any of the positives. Our conclusion is maintenance of biosecure environment is very effective and crucial to minimize COVID-19 outbreaks during ongoing cricket tournaments as long as the pandemic lasts. I acknowledge the Institutes of Sports Medicine, Sri Lanka and Sri Lanka Cricket and the Ministry of Health, Epidemiology Unit and the Ministry of Defence. Thank you.